and video. Yeah, okay, so I cannot start my video. They can start my video. Okay. So, ladies and gentlemen, Professor Anita Shenoy, Professor Manjunath Prabhu, and other esteemed colleagues from Manipal University. It gives me such great pleasure to be here, and bear with me if I just say a few words before we get started on this very important topic of point-of-care ultrasound and the value of it. I just want to start to say thank you very much to not only Philips, who is a big supporter on our side here in our department, but also our AVICOM, Suleiman Razak and Craig, our audiovisual people, and also Paul Rousseau, who spent a lot of time setting up. It was, as the previous introducer mentioned, it's technically quite difficult to do something in such a remote location and on a distance. But it gives us great pleasure to be part of your refresher course and workshop. I met Professor Shenoy, Anita, in 1995 when I arrived in Leicester, and we were working together there as colleagues, and I immediately saw the value of the interaction with a fantastic up-and-coming developing world like India. Very similar to what we've got in South Africa. And I think we can draw parallels between our two countries, except that everything you do is about 1,000 times bigger than what we are doing because of the number of people and really the success stories you've got over there. So I work here at this hospital, Groote Schuur Hospital. Let me just do the advance. It doesn't seem to advance on my side, Paul. The slide, just to advance it. Has it advanced on your side? I'm just going out. We just our advanced stop share. If they can make me in control, your technical people put me in control of the screen, then I can do that. Just 1 second.
Just go back to the original.
Okay, that's good. Okay, let's try again. So I work here at Groote Schuur Hospital, the one on the left, and if you think 1967, the first heart transplant Christian Barnard did right under that tower on top of the old building. We now have a new building connected to this old building and where we perform our daily services. The hospital on the right is the Red Cross Children's War Memorial Hospital, and that's been there since after the Second World War, and all our pediatric work are being done there. And it's really a privilege to work in this institution at these hospitals. Our Department of Anesthesia and Perioperative Medicine consists of about 110 members, made up of half of them trainees and half of them specialists. And it's a medical training, anesthesia training department, like in general, like probably I would guess Manipal is. I visited Manipal in early 2000s and I was impressed with the level of anesthetists it produces. Now, we are also specializing in certain subspecialties, but today I'm going to make an effort to try and introduce you to the value, why our people are using point-of-care ultrasound in our day-to-day practice to improve the outcomes of the perioperative outcomes of our patients. Now, I'm going to start just with a little bit on equipment. Point of care and lung ultrasound is all going together, whether it's transthoracic or the lung, and we use different types of transducers for the different needs that we need ultrasound for. So point of care echocardiography, we will use the phased array, and you can see the frequency of those transducers. That's the cardiac probe at the top right. Then point of care lung ultrasound, curvilinear, and also the abdominal ultrasound. We may use the curvilinear transducer, a bit of a higher frequency. And then vascular access, we will use the linear probe with a higher frequency. And the reason is that there is a trade-off. When you use a higher frequency transducer, the ultrasound signal does not travel that far through the tissue. So you can imagine the heart is further away from a vascular structure, maybe in the pulse when you scan to put an arterial line or a central line in the neck. And we use the transducers for what they are, the need is on the specific time. Now, I have to give credit to Professor Erik Sloth from Aarhus, Denmark, who is also a good friend, and some of you may have seen him at Indian ACTA meetings or other meetings. He's been all over the world talking about point-of-care ultrasound, and he says it's not there to replace a clinical examination. No, it's there to, when you look at all these special investigations that we need to investigate a patient who is critically ill, point-of-care ultrasound is the tool that we take to the patient. It's the tool that we hold in our hand and take to the bedside, and we connect it. It's an extension of our clinical examination. It does not replace all the special investigations, and definitely not transthoracic echo. So we work very closely, just a word of caution, we work very closely with our cardiologists. We learn a lot from our cardiologists. We are not a threat to the cardiology practice. No, we are complementing them. So people are picking up pathology in the operating theater, which was not expected. And this is how we're going to demonstrate, and I'm going to use this presentation as an introduction, and then we'll see how we use a few examples. Now, if you see point-of-care ultrasound as a spectrum, you can take it in a temporal spectrum, so pre-operative, intraoperative, and post-operative, and everywhere it has value. So pre-operative, the patient may present with a normal cardiovascular hemodynamics. Intraoperative, there's a big insult maybe, or an injury to the heart or the vasculature, and therefore intraop and post-operative, it may be totally different from what you start off in the pre-operative patient. And we can do this when we can also draw a spectrum with a type of expertise we have. So if you put FATE, or focused assessed transthoracic echo, as Erik Sloth mentions it, or focus or emergency echo or non-cardiac echo on the one side, and you put the advanced ultrasound on the other side, where you may need a very specialized operator. Maybe if your institution are regularly involved in mitral valve repairs or TAVIs or the MitraClip interventions in the cath lab, then you'll be extremely good at it. But it is not expected that everyone will have that expertise, only if you're using it. So in between comes the spectrum of in-between point of care ultrasound, where you use it as a monitor, either in theater, in the pre-op assessment clinic, or afterwards in ICU. Then, of course, with cardiac surgery, we will use transthoracic and or transesophageal ultrasound. Also in vascular surgery or any high-end, high-risk surgery. We can introduce 3D echo at that stage. We can talk about tissue Doppler imaging or myocardial deformation quantification. All of that are special skills that we will use, and is not necessary. Remember that 90%, 95% of the value that echo brings to our patient happens in the point of care. Yes or no answer. It happens where you detect something that was not discovered before, some pathology. And there again, I give credit to Erik, who has come up with this publication in 2004, and probably one of the first point of care publications. He talked about a directed hemodynamic assessment and the use of transthoracic echo. He said it's not replacing, but it's an extension of your clinical examination. And it may be a monitor even, because things may change during the procedure or the intervention. It is directed at a very specific clinical question. So it's yes or no. Is the heart empty or is it full? Is there a pericardial effusion? Yes or no. Is the heart failing? Yes or no. Is it dilated? Is it hypertrophic? Is there a wall motion abnormality? And there you need different varying levels of expertise to diagnose advanced pathology. But it's very easy to diagnose simple pathology, like an empty or a full ventricle, and we'll show you, demonstrate that later on during this session. It is very, of course, operator dependent. But where do you start? When is an operator accredited or good at what he's doing? We'll talk about that. Nowadays, with the introduction of the small handheld, this is the V-scan. It comes from GE. That was the first of the small handheld machines, but now we've got it from all the vendors, these smaller machines, and lots of others who are not mainstream industry who have come up with this, and people are using it all. So the genie is out of the bottle. It is now not just in the remit of the cardiologist, no. Anesthetist, intensivist, pulmonologist, you name it. Those people, critical care specialists, or just pre-assessment doctors will use this, and you can take it to outside of a specialized unit if you've got an operator who is skilled. By the way, Eric came up with these cards, and some of you may have seen it. It is there for a download on his website. You can go and search for it. It's free to download, and it's wonderful if you want to go through step by step on the FATE protocol and how to get it. Now, since then, many different protocols and people have come up. I'm just talking about FAST, which comes from the trauma fraternity. Feel and Fear, emergency doctors and resuscitation. Raoul Breitkreutz and friends. Focus, the Americans, but see, 2010 they come out and they introduce it, they realize that the Europeans have really made big inroads into this point of care echo, and they have to step up, and now it becomes a turf almost. The heart scan from Colin Royce and friends in Melbourne, in Australia, and everyone more or less come up with the same protocol. Since then, there are many of these abbreviations, FICE, FREE, FAF. You can just imagine anything with an F, and people put it to point of care ultrasound. So it doesn't really matter. It is all an extension of your clinical examination, and it does not replace a cardiologist. So this was the heart scan and a publication with it from Colin Royce. All of the guidelines are more or less the same. It's all operator dependent. You all have to learn and practice it to get better. There's a learning curve. None of it is a comprehensive echo examination, but you can answer a very directed question very easily. There's FAST, coming from the trauma doctors. And again, it's got its people, the trauma speciality are doing their own courses and running their own protocols in their specific practice. Then Fear and Feel, I've mentioned Raoul Breitkreutz from Germany, who sort of pushed the emergency and advanced life support use of and how to do it. Then Focus from the Americas and their enthusiasts there. Professor Alicia Dennis came from Melbourne, and we were privileged. She spent a bit of time with us. The introduction of transthoracic echo in the obstetric anesthesia and obstetric clinical illness. And we're privileged that Mattis and some members of our department have published on this with Professor Dennis, who's really a big endorser of this skill in the in the obstetric field. There you go. Professor Dennis, Professor Rob Dyer, and Matt Gibbs certainly have been pushing the limits since the early 2010s. I've been privileged to be involved in the Critical Care Society and the introduction of echo in the critically ill patient. And it's just to give you a bit of a history when the Critical Care Society, the British Society of Echocardiography, and ACTA, the Association of Cardiothoracic Anaesthetists, got together in the sort of middle 2000s and realizing that this is now hugely important, and trying to set up an accreditation process for ultrasound. The first pilot study in October 2010, and at that time I was part of setting this exam, but I thought it was driven by a group of people, different specialities, and I thought I have to sit it too. So I sat that exam too, and it was really an eye-opener to see how you know, this can have an impact on these different specialties. Suddenly we're away from just cardiology, we're across disciplines. It is you taking this tool to the critically ill patient. The first BSE Intensive Care Society examination was in 2012, and since then it's been ongoing. Then came the enthusiasm big time, and all of these people on this paper have been big enthusiasts who have been pushing for this. So one focus is almost like a religious movement of ultrasound. People have been scanning everything, eyeballs, the heart, the big toe, you mention it, and people will be putting an echo ultrasound probe on that part of the body. And so it has started to find its place. And a lot has been published since. Emergency echocardiography then came from the cardiovascular medicine fraternity. So if you look at the authors on this paper, I know Sasha Neskovich very, very well, and most of the authors there. Now, there is not one anaesthetist on there. This came out in 2013. This is after Eric has been for 20 years been pushing it and trying to introduce it. So there's, by the way, Fabio Guaracino, I correct myself, is an anaesthetist and the present president of IACTA. So it is hugely important that they then realize that this tool is available to non-cardiologists, and they have to have a statement around it. And very interesting, when you look at the publications which followed and came from the same group, they say there is a trend of rapidly growing use of echocardiography in emergency settings by non-cardiologists or cardiologists without specific expertise. We are also witnessing an evolving trend of using cardiac ultrasound examination as a bedside, point-of-care diagnostic test in emergency settings. Examination, name, focused cardiac ultrasound or focus. Now, they're making that statement almost as if it's a sin to have a probe in your hand. I want to say, it is not like that anymore. We're working very closely with our cardiologists, and in most places around the world, people are doing, and anaesthetists are involved. Let me also say that the more you go towards developing countries, like our own country, the more you go outside of big centers of expertise, where you've got a group of cardiologists in a department where they can easily provide a service. The more you leave this and go to the rural areas and the countryside and the smaller hospitals, district general hospitals, the more valuable this tool becomes. That is very important. So in the developing world, the use of ultrasound by a doctor, any doctor, is better than not using it at all. You need the on-off button, you need the basics, you need a training course, and you need to know your own limitations. You are not a cardiologist, you're not replacing that. But if you see something, then it's important. They say a fool with a stethoscope is also a fool with an echo probe. So if you can use a stethoscope wisely, It doesn't mean you're going to diagnose everything with your stethoscope, but then you can use, you've got insight to use a transducer and an ultrasound machine wisely. And it's about knowing your limitations. So we talk about competence and standards all the time when we talk about accreditation. And this thing about competence, they say, oh, it's used as a God term or a rhetorical trump card, regularly played as the last word in debates about how health professionals should function. So they say, ooh, can't use it because you don't have accreditation. No, you should start something somewhere before you get accreditation. So there's basically a time-based curriculum versus a competency-based education. And it depends where you are learning, what your exposure is. If you connect yourself to somebody who's proficient, then you can become very, very good. Of course, we all want to have a certificate and a qualification in the end, and that's what we're aiming for. So we know about this training pyramid, and I'm going to go back many, many years in the history to Michael Cahalan. We use the words when expertly used. And Professor Jack Shainwise, also from the States. And these were gurus who introduced transesophageal echo into the cardiac practice, cardiothoracic surgical practice. And also early on, he said, perform a complete examination. So when you listen to those people and you try, you're going to learn. And you're going to start with focused ultrasound right here, whether it's transthoracic or transesophageal, and you're moving to the top where you become a real trained operator and an expert who can teach other people. I want to just say a few words about transthoracic and transesophageal. Today's presentation is not about transesophageal echocardiography, but the TOE is just a different window. Anesthetists, and especially cardiac anesthetists, often learn their trade of ultrasound through the transesophageal route, while cardiologists or emergency doctors or young doctors who have not had cardiac training will learn through the transthoracic route. And nowadays, every critical care unit, ICU, emergency room, front room, has got an ultrasound machine and a probe. And it depends where you are coming from, how you will learn. And at the end, it's just a different view you are looking at, a different window you are looking at. So it's whether it's the esophagus or the chest, you recognize a pattern. And you must know what a mitral valve looks like, what an aortic valve looks like, and what a left and right ventricle looks like. And then you start to recognize those structures the same way as you would recognize a chest x-ray or an ECG, and you learn to interpret those special investigations. So TOE is really complementing transthoracic echo, and that's all I want to say on this topic. People have looked at this and how much in a critical care unit, often transthoracic echo is difficult to get a good window. Why? Because the patient's got pleural effusions, pericardial effusions, tamponade, dressings on the chest, wires of electrodes and ECG wires. So it's sometimes difficult. It's more difficult to turn a patient on his left side to perform the investigation. So there is no doubt that transesophageal gives you a crystal clear picture, but you need to have some sort of experience to how to put a probe down and how to, it doesn't come without its risks. So I'm going to start now. I hope you can see this image move. This was taken with a V scan from GE, and that is just a lung with a pleural effusion. You put that on the chest of a patient, and this patient, if he's hemodynamically compromised, needs a chest drain to drain that pleural effusion. Very easy. When you see that type of tiger claw, then you know there's about 500 mils of fluid in that patient's pleural cavity, and it needs to be drained. No point in adjusting the critical care settings of your ventilator because the lung will not expand and get rid of the atelectasis unless you drain that effusion. Now, I'm just going to say another word on guidelines and indications for ultrasound. Many have come and gone. People have published widely on when should you use it, when should you not use it, when is it a risk. at the end of the day, the sicker the patient, the more important the information it provides. And we can almost, at the top, number 1 point, bullet point on every one of these lists, is when the patient is hemodynamically unstable. Then the value of ultrasound is huge, and it tells us a lot. I'm not going to go through the rest of the list because that's specific to transesophageal echo, but whether you have TTE or TOE, hemodynamically unstable patient is valuable. Now, transesophageal echo, again, there's been a point of care, a statement by the SCA to come up with a point of care. So abbreviated transesophageal echo examination. You may remember or recall that in 1998-99, Professor Jack Shainwise came out with the 20 views, and some of you may have learned it or studied it, but there are a few basic views with transesophageal echo where you get the maximum hit for your buck, or what do we say, the maximum yield for your examination. That's not what we're going to focus on. How should I use point of care in my daily practice, and how can I incorporate it? We will talk about it again over the rest of the session. Just to say, Dave Canty works with Colin Royce, he's a good colleague and friend, and they've done, in 2012, they've published this paper where they, what is the impact? How does it make a difference? But remember, it is very difficult to judge the impact of a monitor. So when you use ultrasound as a monitor, it can be incredibly valuable. Just give some volume, or you don't need more volume. But if you use it as a diagnostic tool in the high end, it can be more complicated. But there can be easy diagnosis which you can make. They've used it in the pre-operative clinic, and they said one of the most important values of transthoracic echo in the pre-op clinic, pre-assessment clinic, is reassuring negative findings. So Matt Gibbs is working in our pre-assessment clinic, and he will tell you all about it later. They would see the elderly patients for hip replacement. The patient comes around and the patient is frail, and there may be crepitations in the lung. They put a probe on the chest and say, no, this patient is not in cardiac failure. That is hugely valuable, because tomorrow or in 2-3 days' time, the patient can go for the operation without waiting for a 6-month referral waiting list to cardiology to get an ultrasound. They also do the 6-minute walk test in the pre-assessment clinic, and therefore can say this patient is cleared for anesthesia, and the decision is being made by an anesthetist who understands the nuances of intraoperative challenge. So they looked at cost effectiveness, cost benefit, and again, the value. It's very difficult to put a monetary value to what a tool will bring to a patient. I mean, the managers will always ask you, but how is it going to save us money? Now, you can say the cancellations have been prevented. We did not cancel this and this and this patient. That would be a very good study to do, Matt, if we look in future. So how many patients did you delay or cancel from their operation next time? And that will be a valuable money-wise, you know, how much does it cost type of thing. I've mentioned the guidelines of, remember we distinguish between an intraoperative monitor versus a diagnostic tool. Diagnostic tool, you may need high-end skills if you want to do detailed quantification of pathology. However, an intraop monitor, I can show you in one afternoon what an empty or a full over dilated left ventricle looks like, and you can say, well, this one is overfull, dilated, or empty. Let's give volume. And that value is incredible. Just an example. These two examples, the one on the left and the patient one on the right, total different pathologies. But the one on the left can do with a bit of relaxation and filling of volume and slowing of the heart. The one on the right, so the one on the left is a patient with concentric cardiomyopathy. There's almost no volume inside this ventricle. You see the kissing of the papillary muscles and the concentric hypertrophy, increasing muscle mass of that left ventricle. And you don't need an expert to realize that that patient is in trouble. Now that can be given, that type of ventricle can be caused by aortic stenosis, hypertrophic obstructive cardiomyopathy, or other types of congenital problems. Essential hypertension can give you a concentric hypertrophy like that. Well, the one on the right is a patient with non-compaction of the left ventricle. You see all the trabeculations in the left ventricle. The heart is dilated. The wall is not thickening. There is global impairment of that left ventricle. That patient will use totally different strategy if that patient is hemodynamic unstable. That patient will need an inotrope and a vasoconstrictor, and maybe looking or carefully guiding the coronary perfusion pressure. Now that patient on the right can be a patient with severe preeclampsia, can be which we see a lot of in our obstetric practice, can be a patient with peripartum cardiomyopathy. We never know when this can appear, and the treatment is very specific. How are you going to manage that patient? Okay, so the question is it absent or not? This was performed in our anesthetic room before a patient came for a VASCATH urgent procedure. The patient's in renal failure, young patient, reported in the past to have good ventricular function, but then picked up the patient, the anesthetist couldn't hear the heart sounds and couldn't feel a pulse very well, and said, but why is it like that? Put a probe on, and there's a huge pericardial effusion. So the transthoracic 4-chamber view, with on the left bottom of your screen, you see the right atrium collapsing during diastole. The right ventricle at the top left of your screen also clearly collapses during diastole, and therefore this patient will have a very high pulmonary capillary wedge pressure, a very high CVP reaching up to 20 maybe even, and a wedge pressure of 20, 25. But it's not that it's failing or overloaded. The impact is from outside the compression, the fluid outside of the heart compressing and impairing the filling of that ventricle. And the picture on the right is the short axis of that. It's a transthoracic apical short axis. And again, not apical, parasternal short axis of that same heart. And we appreciate the pericardial effusion around. So immediately you know this patient needs drainage of that fluid to have a good hemodynamics. How did we go about? We started educating and training our people in the early, well, in 2012, 13, started running courses, not only for our faculty, and I'm very proud to say that our consultants, especially the younger ones coming through, are all very proficient in holding the transthoracic probe. And it's at different levels. I mean, Matt Gibbs himself, who you will see afterwards, is running courses himself, together with other colleagues in our department. There are several people who can run these point of care courses, but Matt at the moment is supervising and leading this program. And we try and get all our new people in the department to go through this. The same for our new registrars, our residents coming through. All of them now, where 10 years ago they may have to do a course to be proficient with this. Now they all come in, and depending on who they work with on the day, the machine is in theater and they will be using it. It is hugely valuable, and the people are hungry to learn. And I'm very proud of that. Although these point-of-care ultrasound courses are very nice, concise, one-day course, actually the real way you are learning is the way Dr. Robert Munsey has learned, is by using it on a regular basis during their training time. And I want to demonstrate you how that happens. We've also come up with a few other ideas. Matt started this Fate Federation, which is just a little WhatsApp group for our department, and every Friday he's been teaching people on whether it's on the simulator, on one of the residents taking a shirt off and they scan the person, and so on and so on. It's just holding the probe, understanding the on-off button, the settings on the dashboard of the machine, and the knobology. Then we have very proud about our sonographer in our department. We've appointed a sonographer, and she's really one of the stalwarts in the department. And usually on a Tuesday or whatever day she's coming in, then we are, the first registrar that can get hold of her will grab and take her to the theatre, and their sole purpose for that day is to train someone, and usually somebody has claimed her, then it's very difficult to give her up, and people just learn, and the learning program, the learning curve is exponential, really. And then we've got WhatsApp groups where we post interesting cases. I'll give you a few examples of how it works, and with that, it actually is telemedicine made easy. People are learning. Of course, there's confidentiality of the patient involved, but people are learning very quickly by sharing their difficult case of the day, and they share to other registrars. And whether you're a senior person or a young person, you look at the picture, and usually there's a question connected to the picture or the video. That nowadays you can take a video with your cell phone of the screen of the machine and put it on WhatsApp, and as long as you don't identify the patient, or everyone is learning, and we're all appreciating the activity is so much more. We started with this point of care ultrasound medical students program, where 4th year we get medical students and 6th year. And then we try and do on a regular basis these courses. Lenore Naidu, who is our in-house sonographer in the department, is very switched on and very advanced with both adult and congenital cardiology and scanning, and very keen on teaching and involved in these courses. So we've got this type of manual we've put together with the help of Eric, and we are now trying to train our medical students on a regular basis. I'm going to stop there. I suspect I haven't kept an eye on the time, but I suspect it's about 40 minutes now. Dr. Manju, I'm happy to take questions now, or if you want to stop, interrupt, then we can catch up in 10 minutes, 12 minutes time when we start again. I want to stop by saying education is not the filling of a pail, but the lighting of a fire. We need to install this keenness with our young doctors. It's our duty to say, go for it. I'm not so good at it, but the people to follow, they must be experts on this. And I would like to think and believe that our trainees, my trainee, my registrar who starts today will be a better product than what I am today. If I don't achieve that, then I have not achieved my goal. So the day I go, everyone in the department must be better and more expert than I am. So let's share information, share this, and we promise to do that with the next part of the session. I'm going to stop